with a link to vote for the best innovation pitch. Now is the time to use that link. You will have until Thursday at 1 p.m. to vote for your favorite health innovation. You're only able to vote once, and the winner will be announced at the closing ceremony on Thursday. Now, without further ado, I'll first welcome Luigi Serio from CERN.
Hello everybody, ladies and gentlemen, good afternoon. CERN is the European Laboratory for Particle Physics. We continuously and constantly develop algorithms and based on artificial intelligence to safely operate, enhance, optimize the accelerators infrastructure. Today, there is a very large amount of data available in various repositories around the world and very large computing power. This repository contains data that sometimes are private, difficult to exchange, and therefore are the bottleneck to train our algorithm. Among the developments that CERN is doing, there are some that are for societal interest, and in particular for medical application. One of these is the project that we are presenting, that is the medical application based on the design, development, and implementation, and now operation of a federated learning platform, the CAFEIN platform, which allows to collaboratively train algorithms based on data that are sitting in individual and private repository without exchanging any data themselves. Therefore, these nodes where the data are sitting can be patients with their own devices. They can be practitioners with their own computer. They can be institute, clinics, or countries with their own larger repository. And the algorithms on the federated learning platform are built on individual training on the nodes and the collective analysis of this and creation of a common algorithm. This has a very great advantage in terms of guaranteeing the privacy of the data, that they will never be moved either from the patients or from the clinics, but also the possibility of enhancing collaboration and exchanging data, thus creating even more and more large and robust model for prevention, prediction of diseases and pathologies. If we push the concept to its limit, we could actually enhance and empower each of the patient with his own data, his own algorithm, taking advantage of the collective model created for the analysis of his own disease. This will propose to society the enhancement of collaboration and guarantee the privacy of the information. The platform is today operational in 3 nodes that are based in Italy, Czech Republic, and Greece, and is actually operating on the model that allows the screening of brain diseases and pathologies based on MRI scanning. The accuracy of the model that we've reached are superior to any of the models that is train on the individual node, and are comparable if you would put all the data in a single node and train it locally. The future plans that we have are to enhance the platform, to extend the collaboration, the participants to other institutes and other countries, to go for prevention and prediction and therapy treatments for other diseases, to install a carbon tracker and a carbon footprint optimizer so that we can have a sustainable computing, a sustainable algorithm, and to try to have also the possibility of empowering each individual patient with his own data and his own model recognition. Last but not least, I invite you to visit us at our stand at the innovation floor. And you can see for yourself the platform running. We have a demo with actually the 3 nodes running, where we can demonstrate online the possibility of training algorithm with data that are sitting in 3 other nodes outside the local site. Thank you, and vote for our innovation.
Thank you so much, Luigi. Well done. Now, for the second contestant, we have Eric Barthe de Sainte-Far representing Alima. You have 5 minutes. Good luck.
Bonjour, je suis Eric Barthe.
Good afternoon. NGO Anima, humanitarian based in Dakar in Paris. I will introduce our project, which is called La Cube, and which often started with a small story. In 2003, an epidemic of viral hemorrhage fever in Angola, and with our medical organization at the time, we intervened on the handling of this epidemic. This was basically in full individual protection. We go into the villages, we take a suspected case, put him at the back of a pickup, take him to an isolation center, and then we wait for see what happens. There was no treatment, no accompaniment, no follow-up, for the simple reason that the protocol was that the priority was to protect the caregivers. In 2016, when the Ebola epidemic began in West Africa, no evolution, we're still in the same situation as a patient. You are a semi-individual separator. Every 3 hours, you have medical staff who comes to see you and speak to you of your illness and to see how you are feeling, and then goes on to the next patient. In the 3 hours that remain, waiting for the next passage, you are alone. You listen to your neighbor who is on his deathbed, and your fear of the illness because of the very high death rate. In 2016, the initiative of Dr. Sakova from Guinea, we decided to review this patient handling and the acute condition of the patients. The A-Cube, it's an individual room which is bio-safe for intensive care or necessary reanimation for the case of the patient with viral hemorrhagic fever. A kit of some 200 kilos with a biosecure case and HEPA 14 filtering to ensure the best level of protection. This can be deployed almost anywhere by 4 people. On this biosecure, you have 2 transparent walls which make it possible to have observation, continuous observation of the patient. One of these walls, which is the medical wall, which has a half overall to carry out medical care without entering the cube. A whole set of devices make it possible to have cables and tubes necessary for the installation of biomedical equipment outside of the cube. Today, with this unit, we have the assurance of the full control of the infectious condition with negative pressure of minus 15 pascals, which has conformed with the New Zealand standards, and one of the strictest to date. The other element which is important here in this unit is that the transparency makes it possible to follow the patient and for the family and the patient to be able to communicate. Today, we can have one member of the family that accompanies the patient that is within this cube, and for the families seeing and understanding what we do. In practical terms, since 2018, we have deployed 52 cubes, basically in epidemics of Ebola-type epidemics. We have undertaken cesareans, deliveries, and cared for over 500 acute patients. This unit has also made it possible to take part in the PALM-1 research project for the identification of 2 therapeutic molecules for the treatment of Ebola patients, and also the revision of the care provided as determined by WHO. We started with Ebola, but today, with this cube unit, we feel that we can offer almost anywhere in the world on an emergency basis in countries that do not have the ability, a intensive care unit, be the disease known or unknown. And in today's world, it seems that emerging diseases seem to be growing very rapidly. Apart from the technical proposal, the results, we would also like to insist on what we have learned. We, humanitarian workers, we're often left aside, and yet we're the first to see the issue, and we try to solve it on our own. Here we have tried to do this differently. We began by seeing our peers, those who are faced with the same issues. The Royal Free Hospital, reference hospitals in France, WHO, the Mérieux laboratory, who all have a part of the solution, and our aim was to adapt them to the present context without losing the medical quality. We've also learned that collective work is vital. Other important issue is that such a project cannot be done without industrial partnership. This industrial partnership has constraints and keeps us faced with facts. At the end of the day, I would simply like to say, in relation to this proposal, that the population, which is very lost in the Democratic Republic of the Congo, when they saw our Ebola treatment center, which we set up in 2018, said the following here: we are cared for just like in Paris. Our proposal is that may not be perfect, but it has made it possible to do this in the Democratic Republic of the Congo. Thank you.
Eric, now our next contestant, I would like to welcome Mayur Shetty from Black Frog Technologies.
Hello, good afternoon. I'm Mayur Shetty, CEO of Black Frog Technologies. We are a healthcare technology startup company based out of southern India. Before I talk about our product, I'd like to share an experience with you. About 5 years ago, an Anganwadi worker or a healthcare worker or an A&M had visited my home to administer pulse polio drops, the oral polio vaccines, to my niece. And she got the vaccines in a chai thermos flask with ice cubes in them. So when she opened the flask, the ice cubes had all melted and there was just water seeping out of it. This was terrible to watch, and I just went, I'm just going to get my vaccines from elsewhere. This is especially critical now in the context of COVID-19 vaccination and the broader mitigation of the pandemic. Most COVID-19 vaccines are freeze sensitive. While Pfizer, Moderna, J&J, all of them require varying temperatures, once they are stored at a static refrigerator at 2 to 8 degrees, they cannot be frozen again. And all across the global south, we take the vaccines to the people rather than bringing the vaccines across into primary and sub-health centers. This is a huge problem, and across the global south, we use ice boxes or frozen ice packs and gel packs in insulated carriers to transport the vaccines. And more often than not, the temperatures inside these boxes go below 0 degrees Celsius, and they render these freeze-sensitive vaccines unviable for use. This causes two problems. One is the obvious. economic burden of wasted vaccines. But second, most critically, we are administering vaccines that have lost the potency. We are giving 2 shots of the vaccines to a person, telling them he's completely protected. He gets complacent, he takes off his mask and he goes out. That is the nightmare scenario. And WHO claims over 50% of all vaccines globally go to waste before they're administered because of poor temperature control. As a solution to this, we've developed Emvolio, which is a portable and rugged battery-powered system that can maintain a preset temperature for 12 plus hours in the field. The device weighs just 5.5 kilograms, can be worn as a backpack or as a sling bag, and holds the same volume of vaccines that a blue box commissioned from UNICEF is able to carry. About 500 to 600 people can be immunized in a single day. A little bit on the underlying technology. So there is 3 aspects to the patented technology we've developed. First is the fact that there is uniform cooling. All of the vaccines are blanketed in air between 2 and 8 degrees. There are no hot spots or cold spots. Secondly, when a healthcare worker has to administer the vaccine, she has to open the lid to either retrieve the vaccines or to put it back. So every time she does this, there's ambient air going in and this temperature excursion. Our system stabilizes the temperature back to safe limits over 96% faster than an ice-based system. So the overall aggregate time that you would subject the vaccines to suboptimal temperatures is minimized. Thirdly, there is an inbuilt GSM GPS system on board. So the headquarters is able to constantly monitor the device. Where is the device going? What is the temperature? Is it safe to administer? What are the hotspots of the disease? Do we vaccinate this particular geography first? What are the outbreak areas? All of this can be monitored as well. The device is compliant with the highest medical device standards, which is IEC 60601, and we just inaugurated our manufacturing plant, which is compliant with ISO 13485 standards, which has a capacity of churning out about 1,500 units per month. We've validated this product in the mountains of Northeast India, in the deserts of Jaipur, in the coast of Karnataka as well. And now, with your support, we want to make this system globally accessible. Our product, one of the most successful use cases we've had is in a remote hospital called Sargur, where they were using our product for administering vaccines to a local tribal community. And they've been using our product for over 2 years now, and they claim vaccine savings worth $200 every single month. And they're able to immunize twice as many kids. So the product is providing them a return within 6 months of usage. Now, in the context of COVID-19, we want to ensure efficacious vaccines reach all of the masses, and every mother and child get access to vaccines that are effective and on time. Thank you.
Thank you, Mayur. Our next contestant, Andrzej Sobkowski from Pristum SA. Welcome. Good luck. You have 5 minutes.
Ladies and gentlemen, good afternoon. Very happy to be here. Do you know that 2/3 of humanity do not have access to radiology? Access does not only mean the actual distance to get somewhere. It also means having equipment that works, radiographers who can operate this equipment, and radiologists, the doctors, to perform the diagnosis. To give an example, in Mozambique, 25 million people, 5 radiologists, a ratio of 1 to 5 million. To be compared against France's ratio, which is 1 to 8,000. And even with this ratio, in France they have created the term medical desert to qualify regions in France where there are no sufficient healthcare services, including radiology. This is not a concern that is specific to low and middle income countries. It is a global issue. It's a global health issue because radiology is critical to diagnose infectious diseases such as tuberculosis, but also for road injuries. And actual fatalities related to road injuries account to TB, HIV, and malaria combined. Studies show that 80 to 90% of radiology issues could be answered by 2 relatively simple equipment, X-rays and ultrasound. Unfortunately, if you take the example of sub-Saharan Africa, 50% of X-rays are not operational. 70% of all radiology equipment lie idle. This is because of complex installation procedures, missing spare parts that are too expensive to purchase, or devices that have not been designed to work in specific harsh contexts. To be fair, in some cases, these devices are second-hand donated devices. In some cases, these are actual second-class devices, only 10 to 20% of which ever become operational. So Prism is tackling these issues via the Globaldiagnostix initiative. And this is made of two macroscopic components, a device and a set of services, the combination of which will significantly reduce the cost for the patient, the healthcare provider, and the payer. So the device first. The device is called Crystalix, and it's the result of years of research and collaboration between universities and industrial partners. It's CE certified. Top-notch components, exceptional image quality. It has been designed ground up for robustness and high uptimes, which means it works in high temperature, high humidity, dusty environments. It has a power supply unit that works on normal plug that can operate for hours on batteries. It can work without any underlying infrastructure, and it is therefore applicable to both rural environments and urban environments. Also, we spend an incredible amount of time trying to make this as easy as possible to use. Intuitive user interface, embedded guides, embedded tutorials, predefined acquisition parameters for the minimization of those. Well, as a side note, and I hope no offense, we've actually had feedback from radiologists, and they have told them that even they could perform an acquisition without any assistance. So one is the device. Two is a set of services, and in particular teleradiology services. The idea is that we spread around the territory the acquisition centers, and these images, thanks to modern technology, are then distributed to the radiologists that are located anywhere around the country. So to sum it up, the need is real and is global. We've made no compromise on the device. Top quality, and it can work in any environment, from the rural, in the middle of nowhere, all the way to the most modern Swiss hospital. And if we put these two together, we will make radiology more affordable and more accessible. Just one last thing, we have deployed a few weeks ago our first device in South Africa. If you want to know more, please come and visit us at our booth. Thank you very much.
Thank you so much, Andre. Now let's welcome our next contestant, Mariano Garcia from MAT, SAS. Good luck, Matt. You have 5 minutes.
Hello. First of all, thank you for having me here. My name is Mariano Garcia. I'm from Medellin, Colombia, and I am CEO and co-founder of MAT Mobility. First, I want to ask you this question. Have any one of you ever felt in any way excluded in anything? I have. The problem that we are trying to solve is the social exclusion that exists to people in general with some sort of disability. If you know, we have more than 1 billion people around the world with some kind of disability. In my country, we have 2.5 million people with disabilities. Of them, 80% don't have a labor contract, 64 of them don't have any income at all, 90% of them need assistance in their daily basis. So this is a huge problem because people with disabilities is the biggest minority in the world. Anyone here can have a sort of disability in any time of your lives. So when we talk about the reduced mobility market, we talk basically about three different people. We have the medically obese people. We also have the elderly. And finally, we have the people that use wheelchair. So we have our solution is what we call the MAT. And it is an integral solution because we have a software part and a hardware part. The hardware part is this device that you see here. You can attach it to a wheelchair. 90% of the wheelchairs, you can attach them. And with this, you will first improve your mobility. So this will give you access to a lot of opportunities. So at the end, it will improve your physical health because now you have like a motorized wheelchair. And this also will mean that you will have mental health. And the other part of our solution is the software solution. We call it the Club 2G because we said that is the second generation, is the people that don't wait there. They want to come and to improve their lives. And it's an app, a software app that you actually can do like 3 different things. First of all, you can map all the different accessibility places that are around you. Second, you will find job opportunities specially designed for the people with some kind of mobility disability. And finally, you get the community because you will also find help for the different things that you get into when you are in a wheelchair. Right now, we are a team of 10 people with different backgrounds in biomedical engineer, startups, and product designers. For the moment, we have created more than 150,000 kilometers with our device. This means like with the creation of our mat, we have given 3.5 times the length of the Earth. It is 40% the distance between Earth and the Moon. And it's 17 times the distance between Colombia and Switzerland. So you can know what we have created here. Right now, we are trying to increase our team. We are looking for different design experts and manufacturing experts. So we want to raise $120,000 so we can improve our product. And my invitation to you is to be more inclusive, to vote for us. And maybe if you know someone that may be interested in what we are doing, we are more than willing to have a small talk. So that's basically it. Thank you very much.
Thank you so much, Mariano. Now our next contestant, Alain Gervais from the Geneva University Hospital. Welcome. Good luck. You have 5 minutes.
Ladies and gentlemen, colleagues, friends, good afternoon. So my name is Alain Gervais. I'm a professor of pediatrics at the University Hospital of Geneva. I'm sure that you all know that respiratory diseases are one of the major causes of death around the world, and especially in low and middle income countries. Just one example, pneumonia. Pneumonia is the leading cause of death in children under 5. Every 30 seconds, a child dies. That means that during my speech, 10 children will die. And this is just unacceptable, and we have to save these lives. Why is this so? First, doctors are too scarce in LMICs and reside mainly in cities and not in remote villages. Second, diagnostic tests such as chest X-ray, CT scan, even PCR are not available. And when they are available, they are not just affordable. And moreover, again, all these tests are in cities and not in remote villages. Do you know that many sick children never go to a clinic because they live far from a facility? Roads are in poor condition, and also transportation is very expensive. In sub-Saharan Africa, where most pneumonia deaths occur, only 2 out of 5 children with pneumonia symptoms receive adequate medical care. So it's really time to decentralize medicine with new diagnostic tools that are easy to use, affordable, reliable, and offer the same quality of diagnosis no matter where you live, in cities or in remote villages, no matter who you are, rich or poor. And this is what we bring with Pneumoscope. Pneumoscope is a medical device consisting of a reflection oximeter on one side and a thermometer and a digital stethoscope on the other side. All these are powered by artificial intelligence to recognize the specific acoustic signatures of respiratory disease. That means that the sounds of pneumonia are different from asthma, different from COVID. And we train our algorithm to recognize these specific acoustic signatures. A bit like your Shazam app recognizes your music. The artificial intelligence we have developed through extensive studies in Africa, in South America, including thousands of patients and 100,000 of respiratory cycles, allow us now to automatically measure the respiratory rate, inform the user if the auscultation is normal or pathologic, and if this is pathologic, can classify the sound as the one of a pneumonia, asthma, bronchiolitis, and so on and so on. In addition, thanks to the oximeter and the thermometer, artificial intelligence can develop a risk stratification of the disease. That means to inform the user if the disease is serious or if this is just benign, to address the patient in the best care pathway. That means that the user can you stay home, this is not too serious, or no, you have to go to the hospital. In addition, because the Pneumoscope is a connected device, auscultation sound, oximetry, heart rate, and all the other data can be sent in real time to a remote specialist also for teleconsultation. The user interface displayed on your smartphone or your tablet is very intuitive and guides the user through the process. You don't need a medical expertise to use the Pneumoscope. That means that a nurse, a community care worker, or the patient himself can use easily the Pneumoscope. And the Pneumoscope is more than only an intelligent stethoscope. This is also a clinical decision tool. Indeed, because a lot of data can be stored in your tablet or in your smartphone. When you have the diagnosis, it can propose the best treatment and the best management of disease. Let's say this is a bacterial pneumonia. Your app can propose, based on your local epidemiology, the best antibiotic to fight bacterial resistance. It can help you for your antibiotic stewardship. In addition, a lot of general data on every disease are stored in your smartphone or your tablet. And then every time you use the Pneumoscope, you improve your knowledge on the disease, and you can have better interaction with your patient. In summary, so the Pneumoscope helps in the diagnosis and management of respiratory diseases and really could save millions of lives every year. It's affordable, it fits in your pocket, does not require medical expertise to use, so can be decentralized in remote villages, in primary care centers, for use by community healthcare workers, nurses, and can be also used for teleconsultation. So the Pneumoscope can replace sophisticated and expensive tests like chest X-ray, PCR, and many others. And finally, improve the user's knowledge and skills after each use. So we need you. If you want to participate to this pneumoscope initiative and try to use it in your field, please contact us and visit us at our booth on the second floor. I thank you for your attention and don't forget to vote. Thank you.
Thank you, Ellen. Now it is my pleasure to welcome our last contestant, Sasha Jalagueda, representing Surgibox Inc. Welcome.
Hello everyone, I'm Sash, I'm from Surgibox, I'm the co-founder and chief development officer. I would like you to close your eyes, but please don't sleep off. So imagine now the earth is shaking. It's an earthquake. And yes, the cupboards are falling on you. You're injured. Many others are like you, injured as well. You need urgent surgical care. But where are the teams? Hospitals are destroyed. There is no infrastructure. Somehow, you're lucky, you survive for 3 days, and you get access to a surgeon. And you have surgery outside. So the surgeon does an incision on you. You have dust and flies going inside your incision. At the same time, your blood splashes on the surgeon, and the surgeon is exposed to your blood. Today, emergency situations, people who require surgical care are not alone. This is a huge global burden. Today, according to the Lancet Safe Surgery Commission, 5 billion with a B people don't have access to safe surgery. Additionally, 18 million people die each year due to lack of safe surgical care. 85,000 providers get infected by patient bodily fluids annually. The best solutions today on the field after an emergency settings are these huge tents, huge containers, huge trucks. But these are very bulky, they cost a lot of money, and especially they take 72 hours to reach the field. In more established settings, surgeries are done in non-sterile settings. At Surgibox, we are here to change the paradigm. Instead of having a whole room that is sterile, we actually focus on the surgical site itself. What it means is that you don't need a full room that needs to be sterile. You just need the space just above the incision to be sterile. And what we have developed is the SurgiField, which is an ultra-portable sterile field that fits in a backpack. This is the size of the bubble. So it's a bubble that you stick on the patient and that you inflate with clean air. Once you have inflated the bubble, providers can access the sterile environment through arm ports. Material ports exist to put in the trays, as well as removing babies after a C-section, for example. This paradigm shift allows it to be battery-powered and can be deployed very, very rapidly. Today, just to give you an example, one diesel generator should be on for the whole duration of a surgery just to keep a stent sterile. Today, currently, Surgibox is in partnership with Doctors Without Borders, and it was born from a collaboration between MIT D-Lab, Massachusetts General Hospital, and EPFL's Essential Tech Center. We have currently manufactured the product under the highest medical device standards, which is, for those standards geeks, ISO 13485. And in the next coming months, we're going to apply for the CE mark so that we have large-scale deployments. Now, imagine tomorrow there's another earthquake, or you have an accident in the Swiss mountains after ski. Safe surgery is available as fast as the surgeons can come. Now, I would like you to do one thing. Could you please take your phones and vote for SurgiField? If you want to meet me, I'm there for the next 3 days. Thank you very much, and have a nice day.
Thank you, Sash. Now, before we jump into the next segment, I'll first leave the floor to one of our important partners of the Geneva Health Forum. Please welcome Casper Wyss. representing the Geigy Foundation, which is dedicated to support the best scientific efforts for the most neglected populations.
Yes, thank you very much. And I think we have heard 7 exciting innovations. I'm sure it's not an easy vote. I must make 2 small disclosures. The first one is I'm stepping in here for the director of Swiss TPH, Jörg Gutzinger, who is only here tomorrow, so try my very best to replace him. And also, obviously, speak here in the name of the Geigy Foundation, which makes available the award for this prize. The second disclosure is, as I have also been member of the committee which had the honor to look at the 91 submissions. It was quite a hard work. It made me definitively a Sunday working, reading all the innovations. It was a very difficult selection. I'm very happy to have heard now 7 nominations, which were really exciting, very nice. I have done already my votes, now it's yours. I'm sure it's not an easy one. I struggled also a lot when I was giving the ratings, so it's now your point. I think the prize is about making an innovation or looking for an innovation which is really making the difference to those most in need, so vulnerables in low and middle income settings. What means that is not easy. Most of us would most likely use slightly different definitions of what are the most vulnerable. Different interest groups also have different understandings, but I'm sure we will all together be able to find the best and most promising innovation. Yes, the last word from my side is was quite a gender-biased innovation. So presentation, if we meet again, hopefully in 2 years again here, I hope also to see in terms of gender maybe a little bit more diversity, and maybe also on my behalf then a women speaking and not men. And in that sense, yes, already now, many congratulations to the winner, which I don't know who it is, but from my side, many congratulations, and also, again, the invitation to go to the booth where the innovations, you can have a look at them. I'm sure you will discover many, many promising ideas. Thank you very much.
Thank you, Gasper. Thank you to all the contestants for making this session so interactive. Now you all have until Thursday at 1 p.m. to make your decisions. Perhaps if you go upstairs to the booths, it will help you decide a little better. So we will now jump to the back of this conference room for a closer look at hydroalcoholic gel in an interview with Didier Pité. Olivia, I'll let you take it from